We have integrated services so that when you walk in, you're able to get STI treatment and screening. Your lab work can be done under one roof. We are able to give family planning methods. So that brought in a lot of people because they would come in for family planning. As they're being attended for family planning, we'd talk to them about PrEP and we get a buy-in.
And then we also had continuous medical education for the facility. We wanted to make the staff aware of the project that was going on in the facility so that when they get people they felt were going to be eligible for this, they would refer them to the clinic for the services.
When we started, our clinic used to run the kawaida time of 8 to 5. And during that time, for example, when everybody has packed their bags and they are going, that's when a sex worker, for example, calls you and asks you, where are you? Are you in the clinic? I'm coming. So we couldn't lock them out and tell them it's past 5. And we started operating from 6:50 and we'd close at 8. We also changed days because during enrollment, they would come in their huge numbers. So we had this differentiated model of care where particular days or particular afternoons would be blocked. Early morning is VIP, mid-morning, adolescents, then in the afternoon would be blocked for demonstration participants and late evening again for the high end. And that worked for us.
Well, for me, it's challenging also because not all the doctors, they are friendly. We also fear because maybe mtu anaweza enda pale and you turn positive and then akwambie, nani alikwambia sijui uende nini? So that's the fear of youth.
We usually get big numbers, especially when you organize for a support group. Actually, it's one of the interventions which has really worked well for us. It's a best practice we borrowed from other programs.
We always sat down and discussed about how PrEPs, the challenges and the benefits and the side effects. With PrEP, there are some people who brought their excuses that they want to stop.
Over time, we have again merged the support groups. For example, if you enrolled in January, somebody who was enrolled in maybe September, the January person is an early adapter. The September person will still be grappling with issues of side effects, issues of myths and misconceptions in the community. So we merge these two people, which I think, again, is doable in real-world setup. We'd have people who'd adapt it early. We'd have people who'd still be thinking and contemplating, adapt it late. If we merge these two people, then the early adapters are able to educate or walk with these people through the journey of adherence, and adherence picks up.
At times, we may find that when you call for a support group, even the clients who don't come for their dates or for their appointment dates will attend. So when they attend the support group, now we incorporate other services alongside the support group.
We also had a hotline number that we gave to these participants, and we gave them authority to either send a please call me or just to flash, and they would be called. This number they would use to clarify some things that they feel are not what they expected, because we told them about the side effects, and we told them should they feel anything out of the norm, they're free to call that number or come to the clinic. If whoever calls the number is the same person who attends to them, then the trust increases. The service provider who they have already entrusted would be ideally the same person to answer this hotline number.